I know we are, and at some point we're going to try and figure out how to actually put them so that you can see them. Right now we're not able to put them on the website, but I may end up somehow figuring out how to put them on YouTube. But I am going to share my screen. So hold on a second. Let's see if I can do this and do it from the beginning of the slideshow. Slideshow from the beginning. There we go. So those of you who are on there, can you hear me? Can you just like unmute?
Yes.
Yes? Okay.
Yes, we can.
Thank you. And again, my apologies for having to delay this, but there was a meeting I absolutely had to attend. So, and it came up after we had already assigned this. Or I would have done it at a different time. But okay, so today what we're going to talk about is chronic pain. Its origins, its implications, and some ways of managing it. And, you know, I would love to say that we don't have to live with chronic pain, and I'm going to dissect that down even more. But I do think that there are ways of mitigating what we end up feeling so that we can end up being the most functional and having the best quality of life. And so I hope that you are seeing my screen here. What I wanted to talk about first was, besides the suffering that people endure, why is the whole issue of pain always being talked about, especially chronic pain? And in the United States, chronic pain is one of the most common conditions that we have, and it's also true worldwide. So I just wanted to give you a few stats. I don't want to belabor this, but I also am going to actually talk to you about how pain is felt in the body, or how it is utilized. And so again, if there's anyone that's saying, "Ooh, this is like more than I want to know," you can certainly let me know. If you have a question, I don't mind you interrupting me and asking me in that moment if you don't think you'll remember to the end, but I will ask at the end too if you have any questions. So I want you to, be thinking about things, jot down some ideas if you have questions, and we certainly will get to them at the end. So in 2019, the US National Health Interview Survey, that is always being done at least every 3 to 5 years, but the collection of the data is always slow, found that in the United States, at least 20% of adults will report pain on most days or every day. And the most common locations for pain are the back, the hip, the knee, the foot, as well as headache. And all of those people claim that it is limiting their daily functioning, which means they can't do their social activities that they want to do. They can't even do sometimes their activities of daily living, and it's interfering with their work responsibilities. And those people with chronic pain do have significantly more work days that they lose out on, that are missed, compared to people that don't have chronic pain. Worldwide, the burden of chronic pain is also escalating, and there are at least 1.9 billion people that reported recurrent tension type headaches, even, which are the most common chronic condition worldwide. And so in the United States, people have tried to calculate the impact of what this pain means on our gross domestic product. And some people have come up with a figure of around $216 billion that is lost. And in terms of lost productivity, about $296 billion a year. So this is something that's really important just in terms of the economy. Forget just the individual person as well. So that's the other reason people want to look at this a lot. So this, and again, I know some of these slides have a lot of information, but there is an organization called the International Association for the Study of Pain that was actually started back in 1973, and that has people from all over the world in all different types of, they're not all just physicians, they are from all different types of work that have at least some bearing on how pain would impact them. And in July of 2020, this was the most recent revision by this organization of their definition of pain. So before we start talking about pain, I wanted to talk about, well, how do people define it? And so over here on the left, people define pain as an unpleasant sensory or emotional experience that is associated with actual or potential tissue damage or would be described as such. So basically, it is a normal response to what your brain thinks is a threat to you. All right. And so the notes that the ISPE also put in that definition are the following on the right-hand side, and that is that pain is always a very personal experience, okay? And that is very important because pain is influenced variably by your biology, by your psychology, by your social factors. And so that would even include emotional, physical, cognitive, spiritual components. And many of those are influenced by your age, by your gender, by your culture, and by your environmental conditions. So this is one reason that pain is so different for every individual person. And we're going to talk more about what the definition of nociception is, but their point is that nociception, and I'm going to describe all of that, and pain are different phenomenon. Pain cannot be inferred only from the activity that's occurring in your neurons, in your sensory neurons, because in the end, it is not necessarily related to the amount of tissue damage that is actually occurring. So through our life experiences, individuals actually learn the concept of pain. We learn pain differently, one from another, which I find very interesting too. And depending on the circumstances that you are in at any given time, even you as an individual will experience pain differently. So every individual experiences it differently, and even an individual experiences it differently based on where they are in their lives and what's happening in that moment. So the other big thing, and why I put it in bold letters, is that the organization really wants to say that a person's experience, the report of an experience of pain should be highly respected. This is not something that one should just ignore or feel like you can just say it's not important. It is very important. And that pain is usually adaptive. That's what pain is there for. It is to help us not be injured, right? And so it may have, adverse effects, though, if it persists past its adaptive role on our function and social and psychological well-being. And again, this is all coming from this International Association for the Study of Pain. And they also make a statement that to verbally describe pain is only one way to express pain. So just because people cannot describe in words what their pain is feeling like does not negate the experience of their pain, right? Because I think sometimes, especially maybe physicians, well, if you can't describe it to me, maybe it doesn't really exist. Well, that's just not true. I mean, think about animals. I mean, they're not verbally telling you what's going on, but clearly they have issues around pain as well. And we can see that. All right, so you can classify pain in many, many different ways. So we ask you about intensity often, like, is it mild? Is it moderate? Is it severe? What's the quality of the pain you're experiencing? Is it sharp? Is it burning? Is it dull? The duration, and I'm going to talk about that more in a minute. Is it acute or is it chronic? Where is it localized? Is it superficial? Is it deep? Is it in a specific place or is it diffuse? And then anatomically, where is it? Is it in your head? Is the hurting in your back? Is it in one of your limbs? Is it in your neck? Is it in the abdomen? And then also you can think about, is this fast pain or slow pain? Because a lot of times neuropathic pain or visceral pain is more slow, as opposed to, I cut myself, that's very fast. So you can think about pain in many different ways. Let's look at it from the perspective of duration. Duration, when we define pain as being acute, we say that is pain that will last up to 4 weeks. And that pain is considered protective because it is serving you in the sense that you are going to be warned that there is a potentially harmful stimulus, some kind of a threat that you need to pay attention to. And it will activate with you sometimes a withdrawal response, like if you're getting burned, so that you will prevent yourself from further harm. That acute pain is trying to localize where you might be getting some kind of a noxious stimulus, and we're going to be talking about that more in a minute. And so let's say it might minimize your mobility so it can promote healing. For instance, if you break a bone and you're hurting every time you try and put weight on it, then you are going to stop bearing weight on that bone so that you don't displace it more, and you will be allowed to promote healing as you go along once you've had it looked at. So that's one thing. And then over here on the right-hand side is this whole concept of chronic pain. So chronic pain is pain that lasts over 3 months. And between the 4 weeks and the 3 months is what we call subacute pain. But chronic pain is thought to be pain that is persisting beyond what we would expect as normal tissue healing time. So it may be lasting for more than 3 months, or it may be coming and going, but that recurrence is still past the 3 months. And it may arise now after the 3 month time frame without any new injury. And that pain may become a burden because it has outlived the adaptiveness, the usefulness that it had when it was acute to start with. All right, so I am going to go through, and I tried to make this pretty basic so that we had a basic understanding of what happens with pain, because this is important to really understand what chronic pain is about and then what we can do to try and fix it. There are 4 steps basically in the physiology of how we process pain. All right. So the first step in that process is transduction. It is what is called transduction. And what's happening is you're converting one form of energy into another. So if you look on the right-hand side, what I'm saying is you have free nerve endings and they respond only to pain. Those are the nociceptors that I talked about earlier, that the concept of pain is not just a nociceptor, okay? In pain, these nociceptors, these nerve endings, are converting these external, very noxious, either heat, which is thermal, chemical, so let's assume somebody hits you with some hydrochloric acid or something, or mechanical, like somebody hits you over the head with a hammer, okay? These 3 forms of stimuli are then converted into electrical signals by these nerve endings when they experience these things. But the electrical signals that these receptors are feeling have to reach a high enough threshold to generate what's called an action potential. So it's not like every little thing that you feel is generating pain, right? I mean, otherwise, if we just sat down on a chair, the impact and the pressure of that might signal us to have pain. But that's not what happens most of the time, because there has to be enough of these nerve endings being signaled that a threshold is reached, generate an action potential, and then that electrical impulse is conducted along the nerve fiber and it goes to the spinal cord. And I'm going to show you a picture of that in a moment. But it is not yet pain, all right, because it hasn't come into the brain yet. So right now, it's only traveled to the spinal cord. So it's just the beginning of a signal that may or may not tell us there is danger. All right, so these receptors that are the ones that are going to respond to these 3 stimuli, the heat, the chemical, and the mechanical, are concentrated in different places in the body. And there are different amounts of them and different concentrations of them in the peripheral parts of your body for the most part. And the majority of them are in your joints, in your skin, in the cornea of your eye, and in your visceral organs. And also there are a lot of them in the fingertips, in your hands, in the periosteum, which is what is around bone, and also on your face. So I think that's one reason that when we talk about acupuncture points being the most active, below the elbows and below the knees, I think part of that is because we are using some of the most critical areas where there is a lot of vascularity and nerve endings. So we're actually engaging that. These pain receptors, these nociceptors, are either specific to one type of pain modality. For instance, they're either going to be heat, chemical, or mechanical, or they can respond to all of them. So again, I'm just trying to set the framework, and don't glaze over on me, but I'm going to actually go through this. I guess I can use the pointer. Yes. Okay. So the second process is called conduction. So now I just told you that the nerve endings, they'll generate an action potential, which is an electrical conductivity that's going to go up to the spinal cord. So that electrical signal, that's what it's saying on the first part of this right-hand slide, is conducted up to what's called the dorsal root ganglia that's in the spinal cord. So I'm circling it here with my pointer. And then from there, it ends up going into what's called the dorsal horns. So these are the dorsal horns in your spinal cord. From there, they are going to transmit to what are called second order neurons, all right? So those signals, that electrical signal that you have just transmitted up here in your body, is now going to stimulate the release of a neurotransmitter called glutamate, okay? And so neurons have synapses. That's how they connect. And so I'm not going to get into that, but so it releases something into the space between the neurons, and that then binds to receptors on the next neuron, which is called the postsynaptic neuron. And there is something called substance P that can also be released and is often bathing the spinal cord. And that really is released when pain is quite excessive. All right, so the signal that is now generated at this dorsal horn is transmitted via what's called these two pathways. These are the lateral spinothalamic tracts, okay? And they are considered to be the main pathways that are related to the interpretation of pain and the electrical signals that are going up. Now, remember that they cross, actually. This is called decussation. So from this side, like if it's going into the right, it's actually crossing over onto the left, and it's going up those tracks, okay? And it is going to go all the way to the thalamus in the brain. All right, so then from there, it's going to go to the cerebral cortex. But so far, these tracks, or where's my pointer, the lateral spinothalamic tracts are conveying information about the intensity, the localization, and the discrimination of what that noxious stimulus was. Are you still there with me? Have you all turned off or not? Because I can't see you right now. Somebody say, yes, I'm with you, or no, I'm not.
Yes.
Okay. Is it making sense? Yes?
Yes.
Okay, thanks. All right, so now we're getting to the third step, all right, and that's called modulation. So this is very, very important too, because you can either inhibit or facilitate the sensation and the electrical activity of these inputs, all right? So there is a part of the midbrain called the periaqueductal gray matter, that's the PAG. So it can actually get input from the cortex up here, and it can exert what are called opioid-mediated inhibitors. And that actually goes all the way down. So if you see here, it will go all the way down to the dorsal horns. And that is actually activated by the medulla, the rostroventromedullary medulla, okay, which is right here. And that actually can tap down the sensation of pain. But then this area here in the medulla that I'm trying to show you, which is the RVM, oops, where's my arrow? Right here, that also it has bidirectional activity. So not only can it inhibit from the top down, but it can also facilitate these signals. And it has an on-off switch. So opioids exert their pain relief by inhibiting the on cells and activating the off cells. but this balance disruption between inhibition and facilitation actually contributes significantly to this development and maintenance of chronic pain states and what we call central sensitization. Because for some reason, these on switches are turned on considerably and the off switches aren't really balanced. And so you're getting a whole lot more facilitation without the normal amount of inhibition that you should be having. And so now all of a sudden, everything is just augmented, right? That sensation of pain is augmented. There's also this idea of the gate theory of pain. And that also is an idea that pain is modulated by nerve gates, all right? And so either these nerve gates will augment or suppress the pain that's felt. And that activity of the nerve gates can be influenced by a whole lot of various factors, such as your mental state in that moment, such as whether you're exercising or not in that moment, such as whether you feel stress or not in that moment. So it's really interesting. You're thinking, okay, these are the descending inhibitory pathways, and these are the facilitating pathways because they're bidirectional. So just remember that pain is not so simplistic. We somehow have this thought that pain is felt wherever, like if I have a cut, that's where I'm feeling the pain. But actually, that is not true. You're not really feeling pain in your finger, because if it were only there and it stopped that cut, you wouldn't note it at all. So that's what the fourth, kind of process is, which is perception. So perception is the interpretation of those signals by the cerebral cortex. And there are a lot of different brain regions, and I'm going to talk about those in a minute. And pain, again, as I said before, depends on many different factors. So it is the brain that decides whether something hurts or not. 100% of the time, there are no exceptions. It is your brain that is deciding this. It is not the bone that you broke or the finger that you cut or the burn that you had when you put your finger on the stove. It was not that decided it. It was your brain. And think about the fact that some of this is very quick to get to the brain. Some of it is slower. I just read this really weird book. I wasn't going to bring this up, but it was more like science fiction. But the whole concept was that nothing is ever, we talk about being in the moment, but if you think about it, the moment is never the moment, because there is always a delay of what you are experiencing in your understanding or perception of what's happening. If you think about that, it's kind of mind-blowing, isn't it? Anyway, the third thing that I wanted to say is that those interpretations depend on the context, your past experiences, and your expectations. So I'm going to give you an example in a minute. So in addition to the sensory aspect, the pain perception absolutely has emotional, motivational, and cognitive components that are processed in different areas of the cerebral cortex. So I just want to show you this kind of picture to say you've got the cognitive centers of the brain, which are kind of evaluative, all right? Those are the thought centers. You've got the emotional centers of the brain that are more about your affect and motivation. And then you've got the sensory centers, which are all about perception of sensation and discrimination. And then you see that you've got the facilitation of increasing pain signals, as well as the inhibition of reducing pain signals that are all occurring also through the spinal cord. All right. So let's continue that whole fourth process, perception. So those components usually account for the associated suffering that is experienced beyond the sensory perception, right? These are behavioral or psychological responses. So again, this concept reinforces that pain is very subjective. And the reason why pain is experienced differently among individuals is because it is so subjective. And again, why it is experienced differently by you at different times in your life, or even in different moments. And the cortical areas that are involved in this processing of the subjective components are referred to as the neuromatrix. And the main players in that neuromatrix are the anterior cingulate cortex, the insular cortex, the primary and the secondary somatosensory cortices, and the prefrontal cortices. And we already talked about the thalamus as well, because that's where the spinal cord input is going up into the thalamus. So the spinal neurons, which are in the spinal cord, so right in here, increase in sensitivity. When I was talking about how there can be that imbalance of inhibition and facilitation, and they will end up actually causing what's called hyperalgesia, which is an increased perception of pain. And allodynia, which means everything hurts now. And actually that happens. The area that you were hurting in before now hurts even more. And actually it's more than just the area. Now you start hurting in lots of other places that you didn't hurt in before. And there was no actual injury to those places to start with. So you have these flooding of all these sensitivity enhancing chemicals, and they swamp the synapses. And then what happens is you even start sprouting more neurons. And so what is happening in chronic pain is that your brain is actually being tricked, and it's operating on faulty information about what is the condition of your tissues. And the reason it's doing that is because it is attempting to protect you from danger, but it's malfunctioning. All right, because if it's 3 months down the line, the likelihood is whatever that original injury was already healed. All right. And so, I mean, some of you may say, well, then no, that's not true, because I still have spasm, or I still have this. And there are other things that may be playing a role in that we're going to be talking about more. But the actual, I mean, if we haven't healed a wound, well, obviously that's because there's a problem in this person with wound healing. Either, they are no longer getting enough blood flow or whatever. But even at that, sometimes chronic wounds don't even hurt, right? So the whole issue of pain is not always around actual tissue damage. All right, so I'm just going to throw this in because for those of you who are saying, well, what about neuropathic pain? So this same organization defines 3 different types of pain. So I just went through what is called nociceptive pain. Okay, so you have an injury, thermal, mechanical, or chemical, and that's how it goes through, your cord. The neuropathic pain is pain that's caused by a lesion or disease of the somatosensory nervous system, but it results from an injury that is actually directly affecting the nerve, or because you have metabolic problems like diabetes or vitamin deficiencies. Now, those do become usually chronic, and they also persist beyond an expected recovery period. But those types of pains also can be modulated to a certain extent by what's happening, okay, within the individual. This was actually new to me because I hadn't really known much about. There now is a classification that's called nociplastic pain. And I'm kind of glad they put that in there, because what they're saying is this is pain that can arise from an altered perception of a pain from the nociceptors, but there's actually no clear evidence of any actual or threatened tissue damage that caused the original activation of those nociceptors. So there's no evidence of disease or lesion that's affecting the somatosensory system that would be causing the pain. But they're saying, but that nociplastic pain does involve some kind of altered processing. Even though there was no physical evidence or recognizable damage that we could put to it. So they're putting like fibromyalgia under nociplastic pain. And I highlighted the fact that they are making a big point of saying this type of pain is not a psychosomatic disorder, which I kind of have an argument about psychosomatic anyway, because how do you separate the brain from the body? You don't. But that used to be the term that we used when we were trying to say, oh, that doesn't really exist, that pain in you. Somehow you've got some other disorder going on here. But they're saying, no, that's not true. Something has altered your perception of pain. even if there was no obvious original problem. I will say this, the reason I even brought up substance P was because they have done lots of studies on people with like fibromyalgia or chronic pain syndromes that don't seem to have an original injury. And they actually did some studies in medical students where what they did was they kept them, they did lumbar punctures, and you can measure the substance P in the central, the cerebrospinal fluid by doing a spinal tap. So they got all these medical students who are willing to be in these studies, and they said, okay, we're going to draw your, we're going to do a lumbar puncture, and we are going to draw out that fluid, and we're going to analyze it. And they looked at that substance P, and it was normal. All right. Then they subjected those medical students to 2 weeks of where they did not allow them to sleep. Really, I mean, they were trying to keep them awake. It was almost impossible, but they did it. Then they subjected them to lumbar punctures again. And this time their substance P was extremely elevated. All right. Then they waited another 2 to 3 weeks. They let them go back to their, and they didn't feel good. These medical students, they were aching. They didn't feel good. Then 2 to 3 weeks later, after they've now been allowed to sleep and to enjoy themselves, they did another lumbar puncture, and their substance P was now back down to normal. What they find in fibromyalgia is that the substance P is elevated, and for whatever reasons, they cannot get it to go back down. So there's some altered problem, right? I mean, in the first group, they did it by subjecting them to to sleep deprivation. But then when they allowed them to sleep again, their body was able to change it back to the norm, right? But some reason in some people, that physiologic change that occurred is no longer being modulated correctly. And so that is very, I mean, that's very interesting and very different. And so we need to figure out why is that happening as well. So I wanted to come back to this slide just to say that pain really does rely on context. This little picture is from a pain workbook that Lorimer Moseley, who's this very famous Australian physical therapist who's a PhD also, but does pain neuroscience, is showing you that in a violinist who gets a bee sting in his index finger is going to hurt a whole lot more than, say, a dancer, because they're not using their fingers to the same extent. And if it's the left hand, that's the one that's always on the strings, it's probably going to hurt even more than the right hand that's just using the bow. And I can tell you from personal experience, and when I was having my first child who ended up being breech, and I had not, long time ago, I didn't have ultrasound. I didn't want an ultrasound to know the sex. So I didn't know he was breech, and I was going through labor, and I'm thinking, okay, I can handle this pain. I can handle this pain. And I finally go to the hospital and say, okay, it's getting a little worse. I think I'm ready to deliver. And then they tell me that the child is breech and they're going to have to do a section. And I mean, it wasn't 30 seconds between the time that I thought this pain is so that I have this child to, oh no, this pain is worthless because I'm not going to be able to deliver this child. My pain went up so hugely. I mean, the perception of my pain increased and nothing had changed other than I now knew that what I was suffering was for naught. And then I started feeling much worse. So I know but we didn't start until 1:15, so I'm good. All right. Factors that therefore are associated with the onset of chronic pain that have been found to be true are the following. If you have significant physical trauma, if you have a fairly significant injury or a fairly significant infection, that might be something that skews the body's ability to somehow reset out of this heightened perception. People who go through a lot of emotional trauma, people who have suffered child abuse, people with really high adverse childhood event scores, they also tend to be much more likely to potentially get chronic pain. People with spinal injuries may also have more chronic pain. people who have been on opioids for more than 30 days. And you would think that that wouldn't be true, but opioid use actually becomes a problem because you start getting more and more pain receptors because there's something called opioid growth factor that starts being changed by the use of the opioids as they interact with the opioid receptors. And that causes more receptors to form, which then causes, in a sense, increased pain. So it's not just about, I mean, that's somehow, in some ways, how tolerance works. People who smoke tend to have potentially more chronic pain. People who have gone through prolonged stress in their life and people who have prolonged very poor sleep can also, all of these factors can be associated with the onset of chronic pain. Now, I'm not saying they're all the actual causal problem, but they are associated with somehow the derangement in the body of this facilitation or inhibition. Factors which can worsen or maintain chronic pain. So we know that when we become afraid that the pain we are experiencing now will lead to total debility, when we begin to think, oh my gosh, this thing that's happening to me right now is so bad, I'm not going to be able to live the life that I enjoy. Or you start thinking that you're going to become a burden to people. And I'm talking about acute pain now, okay? This is acute pain, less than 4 weeks, but you're experiencing it to such a degree that you're thinking these things in your head. That's called catastrophizing. And Annie used to say it, we like to say it too. It's holding these limiting beliefs because in that moment, maybe you never experienced pain like that. Or maybe you're one of those people like myself when I broke my heel and I thought, I don't have time for this. You know, this is like not what I want to be happening right now. So then we move to these, oh, the most horrible case scenarios. And of course, I mean, this is my saying that this is fear, assuming that we have ruled out that nothing really bad. I mean, that the pain isn't from a cancer, you know, that's eroding something. I mean, so we know that we know what has happened. We know nothing, you know, horrible is occurring. And yet, if we have these thoughts, that could worsen or maintain us in chronic pain. Then there's also this, what we call fear avoidance behavior, and it can be overt or it can be covert, and it prevents us or postpones us for wanting to do anything that might actually cause us a little more discomfort, because we, and rightly so, think that if we hurt, that is a signal that we are doing damage to ourselves. So then we think, oh, if I'm hurting, I better not do that. So then you prevent or you postpone doing anything, right? And once you've acquired this kind of avoidance behavior because of fear, it's very persistent. And when you don't have the pain because you're not doing anything, well, then that actually just reinforces the avoidance behaviors. And then eventually you become deconditioned, which makes it even worse. Depression can worsen or maintain chronic pain. Anxiety or being in sympathetic overdrive, you know, if your adrenaline or we also call it norepinephrine and your cortisols are good, well, you want them in the short term, because if you have to respond to some kind of a threat, you know, if you've just gotten cut and you need to staunch the bleeding and you need to get something wrapped around you, well, then you need to act, right? So in the short term, with immediate danger, it's good to have these high levels of norepinephrine and cortisol. But chronically, you don't want to have those high, because they will then magnify the danger messages. And when you start magnifying the danger messages, then you have more pain. Again, the same thing with the poor sleep, right? That could also worsen or maintain it. And then sometimes interpersonal environmental reinforcers of your behavior also maybe could make it worse. So like if you're always guarding and protecting, because everything, little movement, you think, oh, that's bad. So that's kind of an avoidance behavior. But sometimes it's other people too that tell you not to do anything because they're afraid that if you keep doing stuff, you won't heal. And that's their limiting belief, but they're imposing it on you. And maybe you take up their fears as well, or you just don't do you don't do any of the things you need to do to heal more. And then the last thing is, sometimes we don't ask ourselves, well, why isn't my tissue? I mean, if I damaged my tissue and it healed, why am I still having this pain? Because otherwise the damaged tissue wouldn't have healed, right? So I think that's what we think is, well, my back still hurts. I hurt myself originally, but my back is still hurting. Well, sometimes it's because of the way we held ourselves in that posture or in the way we were walking. Oh, I hurt my knee. I started altering my gait so that I wouldn't get pain while you were trying to let it heal. But now you continue to do those things because they became kind of a habit, and those cause you other kinds of pain. So they put other parts of your body at risk or injury. So it was not even the original injury. It's now what's happening as a result of behaviors. So all of these things I'm talking about, because if we don't recognize these, then we can't get out of getting away from allowing the acute pain to inform us and then let us heal. And this is not the greatest picture, but I had to take a picture of it onto my phone to put in here. And this is basically showing what happens over time with chronic pain. So over time on this axis on the bottom, you see that this is as time is extending. The y-axis would be the activity as the higher up at the top is most activity. The little pink is your pain zone. And this purple up and down is basically you saying, okay, I'm going to try and beat the pain. So your activity is going up and then boom, you start hurting. Now this could be in the acute phase, right? Oh, I'm hurting. So your brain is saying, you better not do that because it's hurting and that's not good for you. Okay, so you say, okay, I better stop. So I'm going to let the pain guide me, and you let your activity drop down. Okay, so now you're not in the pain zone anymore, and you're feeling okay for the moment. And actually it's a crash. They're showing you that you were really, really hurting, and really now you're in crash mode and you're doing very little. But now you start feeling a little better and you think, okay, I'm going to try this again. So you do something again, but now you have a flare up, but still the pain is high and you're not even to the level you were originally. So you go, I better not do that again. And you say, okay, that was a bust. And your brain is saying, whoa, it hurt again. I'm doing myself damage, better not do that. And so you can see that what's happening over time is every time that happens, the pain comes on sooner because your recognition of what happened experientially before is now informing you, don't do that. And so it's just a vicious cycle that continues. Now, this physical therapist, if you haven't watched his YouTube where he talks about in his Australian accent, which is hysterical, how he was walking in the bush with a friend and he feels this little like prick on his foot. And he keeps walking because he thinks he just, got either bitten by a bug or he got a little stick that kind of hit him. So he walks it on, and all of a sudden, the next thing he knows is that he is in an ambulance on his way to the hospital because he was just bitten by a venomous snake. Well, he ends up in the hospital, very, very ill, almost didn't make it, but does make it. Okay, so fast forward to months later, he's in the bush again, same friend, walking basically in the same path. And all of a sudden, he feels the same kind of little prick that he felt the original time, which he totally disregarded the first time because he thought it was just a little branch or something, but ended up being a venomous snake. And this time, he is in agony. He is in excruciating pain and he falls on the ground and he goes, oh my gosh, I am tormented. I think I just got bitten by a venomous snake again. And he's reliving every experience, everything that he can remember about being in the hospital and the ambulance. And this time his friend looks down and says, there's no snake. It was just a little branch. It hardly cut you. So his point is, that again, this is all about context, all about experience, all about what our brain is going to try and tell us based on what it already knows and what it has experienced in the past. All right, so how do we address? So let me see. Oh, good. We got 15 minutes and I think I can go through this because much of this is what we talk about a lot in terms of just health in general. What are the components that we need to address then when someone has chronic pain? Well, the first thing is we need to address movement as well as maybe having physical therapy. But for people with chronic pain, you really have to pace yourself. You cannot just think that I can go back to where I was before. That's not going to happen because your brain, you will hurt more and your brain will tell you you're hurting more. So I'm going to show you later just like a little way that you can start pacing yourself. And of course, we're going to talk about nutrition, and I'm not going to delve into that very much just because anti-inflammatory foods are much better for you. If you eat pro-inflammatory foods, well, you're going to end up with more inflammation and you're going to have more pain. So that's going to be important. And then just your self-care aspects, all the psychosocial stuff, and we'll talk about that more. I will talk a little bit about medications, although, you know, and really, I won't go a long way into this, but I do want to mention that we could have a whole nother talk just on some, like the low dose naltrexone I'm going to mention. But what about medications? And then what about other interventional modalities? So let's look at medications for a minute. Of course, in the acute phase, we always talk about nonsteroidals and acetaminophen. Well, we can still use them even in the chronic phase, okay? You know, a lot of people use tricyclic antidepressants for chronic pain. We use the selective norepinephrine reuptake inhibitors like duloxetine, right? The gabapentinoids or gabapentin and Lyrica, which is pregabalin. These things are all used for chronic pain. And then the opioids, which frankly, it would be better not to use so much opioid because as I said to you before, you use opioids for more than 30 days. And a lot of times that just continues this whole kind of chronic pain pathway. The low dose naltrexone, I want to talk about that for a moment. And, you know, I have some people on it. Naltrexone is in the family of naloxone, which is an opioid antagonist. It is you guys probably know it as Narcan, which is used for people who are overdosing on heroin, and people carry around those pens and they can, you know, inject it just like an EpiPen. That's what they're doing. They're giving them Narcan to try and counteract the opioid effect, right, of the heroin. But I'm talking about low dose. So in those cases, you're talking about 50 to 200 milligrams. In low dose, you're talking about 1 to 4.5 milligrams. And there is even ultra low dose naltrexone that I'm not even going to touch on, but it is used for trying to wean people off of opioids. And we haven't done that much, but you know, there's more and more data on it, and I might actually try and use it. So let's talk about low dose naltrexone for a moment. What I do want to say is that many drugs have two, what we call isomers. They're like mirror images. So naltrexone has what's called the levo and the dextro, the left and the right isomers. The levo one of naltrexone is the one that blocks the opiate receptors, but it's only blocked for a very brief period. That also increases natural production of anti-inflammatory endorphins. So that's good. It'll upregulate the opiate receptors, which in the short term may be a good thing, right? And it has direct effect on some cell proliferation rates. So that's what the levo side does. The right isomer blocks or antagonizes what is called toll-like receptors, and I'm going to mention those. That isomer reduces the production of the pro-inflammatory cytokines like interleukin-1 and TNF-alpha, nitric oxide, NF-kappa B, okay? So those are all pro-inflammatory cytokines. So it's reducing the production of those. It'll suppress cascade inflammation, and it has central and systemic effects as those toll-like receptors that I'm going to mention on the left here are present, and they are present on these microglial cells, as well as mast cells and macrophages. And for those of you who don't know, microglial cells are these inflammatory cells that are around the neurons that help support the neurons. And you can see that if you have activation of the glial cells, you might have insomnia or centralized pain or pituitary overstimulation or neuroinflammation or chronic fatigue or depression. So we don't want to activate the glial cells. We want to deactivate the glial cells. Mast cells are what release, especially with allergies, when they're going to release histamine. So like when you all get all congested or you get welts or urticaria, okay, those are all histamine reactions, right? Many of you take antihistamines, like Claritin or Zyrtec. Okay, that's what mast cells release. And then the macrophages are types of white cells, right, that come out when you have infection or stress. But these toll-like receptors are these family of proteins that are involved in the initial phase of host defense against any invading pathogen. And they act as the primary sensors of of any of these microbes, right, the microbial products. They activate the signaling pathways that then lead to the induction of the immune and the inflammatory genes. So now Trexone, as you see, and I'm going to say it again, the dextro form blocks or antagonizes some of those toll-like receptors. So then it is stopping this signaling pathway. It is stopping some of these inflammatory genes from being induced and sending out all their signals. Okay, so at some point we can talk about that more, but I need to move on because I don't want to keep you all. The other interventional therapies, and I'm going to start with the more invasive ones, and some of you have already had them, like injections or even surgeries, like epidural steroid injections. That's a steroid being injected around a nerve root in the spinal cord, right? Because it'll decrease inflammation sometimes, but it wears off. And of course, you'll have to continue to get them. The medial branch blocks are where you actually cut the nerves that innervate the facet joints. Now they'll grow back, but they also help for, 6 to 12 months potentially, but you have to do it again. There are geniculate and obturator nerve blocks. They also, you can kill those. That's the ones that the geniculate innervates the knee, the obturator innervates the hip. So especially like in people who've had replacements and for some reason we can't get their pain to go down, even in the face of a new joint that looks perfectly okay and we can't see what's going on, well, you could ablate those nerves, but again, they'll come back and then you just have to do it again. People with, arthritis can get hyaluronic acid, which is kind of like a lubricant that goes into the joint and can help for many, many months. Really doesn't have a significant downside other than cost, I guess, and having to inject it. Steroid joint injections, which are very short-lived and in the long run, I don't think are all that useful, but in the short term, definitely can help if you're trying to avoid a joint replacement in the immediacy, or if you're going somewhere and you're going to be on a trip and you say, I just need something to clear this up right now until I get back. But, steroids can always have their side effects and actually atrophy some tissue. Platelet-rich plasma, well, I could go a lot on that one because I think that's very useful. And then this is the minimally invasive laminectomy that can be done for spinal stenosis. And then there are people with spinal cord stimulators. So all of those things have their role and they can play a role in different people. But again, I'm not going to go off on that one right now. But then you can use cold or heat. You can use transcutaneous electrical nerve stimulators. You can stretch. You can use massage. You can do exercises. There's integrative manual therapy. That's a form of physical therapy. There's Feldenkrais, which is a form of movement in space that's physical therapy. Some osteopathic manipulation can be fantastic. And there's even a subgroup of osteopaths that learn this. Acupuncture definitely has been shown to have improvements in outcomes in pain, because we've actually proven that they make changes in your serotonin, which is one of your neurotransmitters that affects your mood, and in substance P levels. Acupuncture has been shown to change substance P levels. So remember that story about the medical students? Very interesting. Maybe that's why some people with chronic pain respond, because we are somehow affecting that. And yoga and Tai Chi also have good data behind them about other interventional therapies. Not every person is going to respond in the same way to every one of these therapies. That's why it's so nice to have a huge armamentarium so that we can see who might respond to what. And so the best practices for alleviating chronic pain is really rewiring your brain and reducing those danger signals, because that will decrease inflammation, let your pain pathways heal. And this is very complex and has to be coordinated. I am not saying it's easy, but there does have to be some daily physical activity and stretching. And maybe it starts with physical therapy, and then you can make sure you do your own daily stretches. And I'm going to show you some. You have to regulate sleep. So we all have to get 7 to 9 hours a night with good sleep hygiene, and if necessary, the addition of herbs or supplements. You want to eat a good, healthy, whole food, non-pro-inflammatory diet. Maybe we can change pain thoughts. Some people are very responsive to cognitive behavioral therapy or EMDR, which is, eye movement therapy that kind of restructures the brain. The stress management and resiliency training techniques that we use, that can be incorporated. We're going to talk a little bit about how do you change your pain behaviors. What about asking family to support your health changes? And then how do you soothe the central nervous system? Well, meditation, yoga, maybe if you're overcommitted, decreasing your commitments, maybe healing those relationships that haven't been so good, maybe spending more time with your loved ones and your pets, maybe taking a vacation if you haven't, being outdoors more, exercising again, we'd have to do that in moderation, and just do fun activities that are fun for you, that nurture you, and always about finding your purpose and then finding laughter. So here is just a picture of some stretching, simple stretching you could do maybe every day for 10 minutes, maybe some gentle yoga or Tai Chi, but of course with posture and breath. And you really, all of us ought to move every 25 to 30 minutes. I know I don't do that all the time when I really get caught up in something, but it's important because your body starts learning those positions and it'll start tightening up on you. And then here's that gradual approach to goal activity. So at first you're down here in the no danger zone. So week 1 and week 2, maybe, you already know that 5 minutes won't bother you. So maybe you do 8 minutes. Even if you feel a little bad, you're not going to let your brain shut you down. All right. And then by week 2, you move to 12 minutes. And again, even if you think you're hurting, you don't let yourself shut down from it. But again, we're doing a very small amount. So then by week 3 or 4, you're going to start increasing it, and see, your brain's going to tell you, I'm in the danger zone. My pain is going up to 8 or 10. Well, we don't want that. So that's why you're doing it very, very gradually, so that by the time you arrive at week 3, we have actually altered the danger zone. So ultimately, the goal level is 30 minutes of brisk activity. And I don't know that this is every person, that by week 6 you're great, but I'm just saying every person has to have their approach and what their goal activity is going to be. And so you can even write it out. There's the anti-inflammatory diet. And then we need to stop. I know, like, we talk all the time about stopping our negative, comments about ourselves and our negative thoughts. But, I realize sometimes, we groan, we grimace, we kind of walk limp, we're limping, or we're walking slowly. We talk a lot about our pain. We rub our areas that are hurting us. Maybe we withdraw from other people, or we limit our activity. So we just need to become more aware of what we're doing in response to the pain, because when we continue those behaviors, they increase the danger alarms in our brain. And we don't want to do that. We want those things to go down. So maybe just saying, I'm not going to do this. I'm not going to groan. I'm not going to grimace. Okay. And then this was what my part was: be with your pets, because they bring you so much joy. I'm not saying everybody's going to move out there and start playing pickleball, but, think about what are the things that once I start feeling better, maybe I could do, and try and be with your friends. Maybe not doing that in this moment when you're first starting, but at least hanging out with them. And that's that picture of this family. Again, maybe you're not going to go hiking right away, but at least you want to be with people that love you. And so maybe this over here on the right is more like, I'll just be in child's pose for a little bit in yoga, just do some nice small stretches, but with the idea in mind that I'm going to have some picture of where I might be down the road in a few months. You're going to have to improve sleep quality. And we talk about this all the time, so I'm not going to belabor that. Okay. And then this is just cognitive behavioral therapy on the left, where we think our thoughts are creating our feelings create our behavior, and our behavior reinforces our thoughts, and it becomes this vicious cycle. So we try and stop that process. And then here's the EMDR, the eye movement desensitization and reprocessing treatment, and just some data on that and how many people have successfully done better with EMDR. And then ask your family for support, and maybe nicely even point out where maybe they are being enabling of this chronic pain, because sometimes they worry about you too, but maybe that's not being helpful to you. And so that's what this is on the left. And then eventually maybe there'll be ways that they can pull you up, right? They can also, not physically pulling you out of a chair, but pulling you up. And this is laughter. We got to have some fun. We got to have something that that makes us happy in life. All right. So I'm to questions. So I am going to stop sharing and see if anybody has any questions for me. Anybody? No, if not, I'm going to try and make these available, but anything come up for any of you? Especially those who have pain? Did you think, well, that's not going to work for me? Or did you think, is there anything new or different about what you heard? You don't have to share, but I'd love it if you would at least say something. Anybody? Are you still there? Did I put you to sleep?